Hello, everyone. We continue with our discussions of the master of the ABIM. So, a couple of more high yield scenarios here. Okay, let's say you get a 67-year-old male with fatigue, okay, and then they give you a EKG picture of AFib and they ask you what's best next step. So they want you to know, like, what's workup, like somebody diagnosed with AFib. This is pretty common in the hospital and clinical setting. So you want to check for TSH, thyroid function test. All right. And what are other possible causes of atrial fibrillation? Other causes: hypertensive heart disease, rheumatic valvular heart disease, congestive heart failure, post-cardiac surgery, coronary artery disease, sepsis, hyperthyroidism, alcohol abuse, thiophyllene, amphetamine, COPD, that's one thing, pulmonary embolism, obstructive sleep apnea, acute hypoxia, okay? So these things that can cause atrial fibrillation, okay? Another case, they bring 37-year-old with wide fixed splitting of S2, okay? And they ask you what is most likely, what are EKG finding? Because everybody knows what's the diagnosis here, right? So you see, this is the second question on the same thing. Everybody knows it's ASD with a fixed splitting. So let's go what you can find on EKG. Okay, you can find out bundle branch block, RBBB. Okay, that's easy question. Okay, now another question they can ask you, like 54 woman came in with proteinuria, right? Urine protein shows 1.5 gram per day protein, right? So they ask you what's the best next step. In this case, you want to give ACE inhibitor. This would be helpful when you have a proteinuria. You can like benazepril. Okay. If somebody hypertensive, okay. Hypertensive proteinuria. Like I said, hypertensive gout, hypertensive proteinuria. So hypertensive management and proteinuria kidney disease, that's what the topic is. Treatment goals: the blood pressure is less than 130/80, and 24-hour urine protein should be less than 1,000 milligram. Here it's above 1,000, so it's high. So first line drug is ACE inhibitor or ARBs. Alternative drug, you can do loop diuretics, especially with edema. You can do calcium channel blocker, verapamil or diltiazem. And there are other non-pharmacologic intervention. You can do like sodium restriction, avoid nephrotoxic drugs like NSAID. So these are kind of the management guidelines. Okay. And now the another case scenario is kind of very high yield as well. Like you say, 47 obese man with nighttime palpitations. And they ask you what's the best next step. Best next step for this patient, it looks like we said OSA can cause arrhythmia at night. So you want to do full night polysomnography with EKG, right? Because this is going to tell us a lot. That most likely this coming from the obstructive sleep apnea. Alright, so now we get another patient, 41, came in with 6 months, 41 man with 6 months history of fatigue. Okay, fatigue, shortness of breath, EF is 25%, and they want to ask you what's the best next step in management. And you do beta blocker, so it's heart rate control. Okay, like after MI or whatever reason for the cardiomyopathy, you want to give them beta blocker. This is high yield, always come in the exam. Okay. Now another question, they tell you, okay, 31-year-old woman came in with mitral rigor, moderate, okay, and pulmonary artery systolic pressure is like 68, so it's high, pretty high, right? So this is a moderate degree of mitral rigor, very high pulmonary hypertension, severe pulmonary hypertension. So they ask you, what is the contraindication for percutaneous balloon valvotomy? What are contraindication to percutaneous mitral balloon valvotomy? Okay. So what are the contraindications? So this one, and then they will tell you as well, like the mitral valve area. So they want to know when do you do intervene with mitral valve surgery, right? So they tell you mitral valve area is like, let's say 1 square centimeter, right? So the contraindications that you want to know. So when do you do mitral balloon valvotomy? You do it when there is severe mitral stenosis, like area less than 1.5 centimeter, plus more than one of the following, like dyspnea or orthopnea, or pulmonary artery systolic pressure more than 50. When is it contraindication? If it's moderate or severe mitral regurg, okay? If there is complex valve anatomy, if there is extensive valve calcification, if there is left atrial thrombus. So here the contraindication is the degree of mitral regurg, okay? It's pretty severe, so you don't want to do that when it's severe, okay? So when do you do that? Indications, if they ask you about it, where there is like severe mitral stenosis less than 1.5 square centimeter, plus symptoms or pulmonary artery systolic pressure above 50. So this patient have high pulmonary artery systolic pressure, okay, and have severe mitral stenosis. We need to repeat it, right? Okay. So, but we can't because of degree of mitral regurg. It will be hard, you know, like mitral stenosis, like they have some degree of mitral regurg. So this is pretty high yield, even for real life. Okay, so now we got this patient. We get 84-year-old woman came in with like some chronic medical issues, dizziness, right? And then on echo it shows grade 2 mid 2.6 mid systolic murmur at the right second intercostal space. So what could cause mid systolic murmur at the second intercostal space? And they tell you, okay, there is some dizzy, and then the patient has a bunch of medications, right? So this is like second intercostal, maybe aortic stenosis, something like that. And then the patient taking hydrochlorothiazide, HCTZ. So they ask you, what is the best next step? This is very common and important, like how to prevent falls in this patient. So you stop hydrochlorothiazide, okay? You stop HCTZ. So how to prevent fall injury prevention? You know, home safety assessment, you do adequate lighting, handrails, grab bars, slips resistant surfaces, shoes. And exercise, you want to do balance training. Tai Chi is good for elderly, gait and balance training. Strength training, aerobic conditioning. Medication modification, reduce discontinue psychotropic medications, benzodiazepine, hypnotics, tricyclics, eliminate non-essential medication. Vitamin D, supplement in patient with baseline deficiency, you know. So you want to stop unnecessary medication, give vitamin, aerobic conditioning, and have good grips at home. You know, this is how to prevent falls, okay? Let's see, another one, 22-year-old African American, you know, came in with septal thickness of 18 mm. Okay, this is like kind of, so my goal is to give you the clue of these high yield words, right? So they'll tell you what is the diagnosis. This is pretty easy. This is HOCM, okay? When you have that much septal thickness, this is HOCM. So this is the difference between athlete heart and HOCM. HOCM, it's common, family history, you see family history. You see left ventricular heart hypertrophy criteria plus depolarization, repolarization abnormality, but athlete heart you don't see that. Left atrial size will be enlarged in HOCM. Athlete heart normal. Okay. Left ventricular cavity size will be decreased in HOCM, but an athlete's heart will be enlarged. Wow, you see? So you make your heart bigger in athletes. Left ventricular wall thickness less than 15 mm. If it's more than 15, that's abnormal. That's too much. Millimeter. Focal septal hypertrophy, you can see that in hypertrophic cardiomyopathy. In athlete's heart, no, you don't see that. You see hypertrophy diffuse. Left ventricular diastolic function, this would be impaired in HOCM. Athlete heart would be normal. Okay. So these are the difference. So that's why it's important. Like if you play sports and stuff, that would be nice to get big heart in a healthy way, not in an unhealthy way. Alright, let's do other questions. Like soft murmur can be normal findings, in elderly. Okay, another high yield question. You see 63-year-old came in with history of lightheadedness, okay, dizzy, woozy. And you see plethoric face and distended neck and upper chest veins. And they tell you what's the diagnosis. There's only one thing that causes that. What is it? They may throw in hollow stomach, murmur, edema, all that kind of things. The one important thing that causes that is superior vena cava syndrome. Okay? This is something you want to know, because commonly due to tumor compression or implantation of autonomic defibrillator can induce thrombosis and occlusion, causing that as well. Okay, so the way you diagnose it, how do you diagnose it? You do CT, chest with contrast, or you can do bilateral upper extremity venography is the gold standard for diagnosis in this case. Alright, you see somebody cough on sacubitril. Best next steps, stop sacubitril. Alright, so let's do a summary of what we discussed. Talked about sacubitril, superior cava syndrome, talked about HOCM, fall prevention. We talked about degree of mitral regurg, polysomnography, heart rate control. Talked about benzapril, right bundle branch block. We talked about TSH. Okay, that's a summary of this section. See you in the